Very good morning, afternoon, and evening to all joining us today. Welcome to this webinar where we will discuss the challenges and opportunities to improve men's sexual and reproductive health with a particular focus on prostate cancer. My name is Samira Suri. I work at the WHO Department of Communications based in Geneva. Before we begin, we just wanted to make sure you all were aware that this webinar is taking place in English as well as in French. You can switch to French on the Zoom panel on your screen now. Over the next hour and a half, we will bring to light the challenges of addressing sexual and reproductive health for men and what we can do differently to address stigma and save lives. Joining us here today is a panel of experts from WHO, the University Hospital of Geneva, civil society, and individuals affected by prostate cancer. A warm welcome to all of our speakers joining us today. I'd like to invite Dr. Bruce Aylward, Assistant Director General for the Universal Health Coverage and Life Course at WHO, for his opening remarks.
Thank you very much, Samira, and welcome everybody to this. I think it's probably our first webinar. Pascal is nodding next to me on this crucial issue that we're talking about today, which is, of course, men's sexual and reproductive health, and the particular focus, as you emphasized, Samira, on prostate cancer. Folks, I was keen to be able to kick this off because, of course, as the Assistant Director General responsible for the whole agenda on universal health care, health coverage, this is a crucial element of what we consider the basic package. And we don't think that way often, that men's sexual reproductive health is as important to universal health coverage as women's, which is more often what we discuss, talk about, and focus on. So I was delighted to have a chance, both as a man and as the ADG, to kick off today's conversation. I think, as most people in the room are aware of, and those online, prostate cancer, of course, a massive issue, the fourth leading cause or fourth most common cancer in the world. And of course, as it's a prostate cancer, it is probably the leading cancer in terms of implications for men's sexual and reproductive health, hence the reason to use that as our entry point in today's discussion. So in our discussion today, this webinar, we have two purposes. The first is an internal purpose, as we're talking to our WHO staff, as well as those of you of other UN agencies and beyond who are joining us here today. And our first purpose, of course, is just to raise awareness, raise understanding among our staff, among the broader community, on the importance of seeking timely health care and support from professionals when it comes to issues around men's health. So we'll talk a lot about that. And then our second objective, and this is looking more at the technical agenda and also our external agenda, is to raise awareness about our work as an organization and how we are profiling the burden of prostate cancer and broader sexual reproductive health challenges among men, the consequences, and also available recommendations from WHO. We have been working on this issue for some time in the area of sexual reproductive health. As well, finally, some discussion about the research and the evidence gaps that we have to address if we're going to be more effective on this agenda going forward. So today, we're going to hear from WHO experts. I think first, we're going to kick off with some of those as they talk to us about the burden of men's sexual and reproductive health conditions. These are quite broad, of course, and then also about prostate cancer specifically. We'll also hear about WHO's recommendations, as I mentioned, on addressing the specific issue of prostate cancer. But you will hear not only from WHO experts, we have both experts and individuals deeply involved in this issue will be introduced as we go along. And I'd like to just offer my warmest welcome. Thank you for joining us here in person today for this important event. Now, folks, as most of you will be aware, and I mentioned this a little bit earlier, most of our work historically and our focus in the area of sexual and reproductive health has been on issues like maternal health, family planning, gynecological menstrual conditions that predominantly affect women, obviously, and very rightly so that we've focused on these. But as we mentioned in some of my earlier comments, issues like sexually transmitted infections, HIV, of course, sexual dysfunction and sexual functioning, infertility. These are also important issues and affect, of course, men. So our SRHR services, which are often, usually need to be tailored, we need to ensure that these meet not just the needs of women, obviously, but also men. Hence today's broader discussion. Now, last year, WHO published an important study on research priorities for addressing masculinities and SRHR, because, of course, this is a complex issue. We're dealing not only with medical issues sometimes, also sexual issues, and also cultural issues, and also individual issues. So there are a whole bunch of complexities. Each one of those are a challenge, and when you bring them all together into one area, of course, you have a particularly challenging area to discuss and to be able to affect and work going forward. And this was obvious in some of the work WHO had done before that study, when we looked at how the socialization of, and cultural issues around men's health was also wrapped up in this issue. And in particular, of course, that reluctance sometimes and other factors that affect the ability of men just to show vulnerability or weakness, which is sometimes what's assumed when it comes to talking about these kinds of issues. And in fact, one of the main research priorities that have been identified in the Lancet study last year was the need to identify more effective approaches for addressing men's sexual and reproductive health. As I think most online or in the room appreciate, men, contrary to women, don't often seek health services, and especially for sexual and reproductive health. Sometimes don't want to talk about it, sometimes don't want to get help. There's a whole bunch of reasons, as I alluded to, that are wrapped up in this issue. But as I emphasized earlier, here at WHO, we see sexual and reproductive health services for both men and women as a crucial part of universal health coverage. So with those comments, I hope I've helped set the scene a little bit for the importance of today's discussion, the reason we are keen to have not just the opportunity for our staff to engage, but also individuals beyond, whether in the UN system or beyond, as we talk about this. And we are hoping the seminar is going to stimulate further discussions, not only among, as I said, our own staff, but beyond. So with that, thank you very much, Samira, for the chance to kick us off, and looking forward to the discussions.
Thank you, Bruce. Thank you for outlining our WHO achievements on men's health, but also setting an ambition for our discussion today. Before we get started with our program, we just wanted to cover a few operational issues. Today, we'll be taking questions on Zoom via the Q&A forum, and as well as live for those that are in the room with us here today. I just wanted to confirm that the Q&A forum is now open, and you can pen down your questions as you hear from each speaker on the panel. Do refer to this. There's a small Q&A icon at the bottom of your screen if you're looking for it. Just a note for WHO staff, this is also being streamed on our internal workplace, so if you have any issues with colleagues trying to connect remotely, you can also direct them to the workplace events channel that is streaming this webinar internally. Finally, let's a quick reminder to all of our panelists here today, just to stick to their time allotted of 8 minutes, so we can make sure we get to the Q&A at the end, but also are able to bring some interesting questions to you from those that are listening online. So let's kick off. Let me start by introducing our very first panelist today, Dr. Nancy Kidula. Dr. Kidula is a medical officer with the WHO Department of Sexual and Reproductive Health. Nancy, could you help us contextualize the issue of men's sexual and reproductive health? What are the most common conditions that are currently affecting men? Over to you, dear.
Thank you very much, and such a pleasure to be part of the panel today, just introducing this issue of men's sexual and reproductive health. It will be quite a short introduction, but we will give time to the other panelists to explore more about the issue. First, we wanted just to say, for those who do not know or who may not be aware of what sexual and reproductive health is, and that is the definition from WHO. It is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity in all matters relating to the reproductive system and its functions and processes. You may be able to see on your right side, we have put the male reproductive health system, and there in the middle, you can see the prostate, which we have indicated in the yellow circle, which is the focus of our discussions today. The prostate is a very, very important organ that is part of the male reproductive system. This is an organ that the female reproductive system does not have. It is unique to the men, and it is the subject of our discussion today. One of the questions we are asked often is that, do sexual reproductive health conditions affect men, and how common are they? By virtue of the fact that one has the male reproductive health system, it means that you can get any of the conditions that affect this system. And they are there, and they are quite prevalent. For instance, we know that 1 in every 3 men has human papillomavirus. Human papillomavirus is the virus that causes genital warts and can even cause penile cancer. So when we say 1 in 3 men, those are quite high chances that anyone can fall in that group. If we look at infertility, most of the time we think it's the women who are responsible for infertility, but in 45% of cases of infertility, the cause can be traced to the male partner. So that is very, very important, so that when we go for fertility care, we need to treat the couple, or to at least examine or deal with the couple and not with women only. Outside sub-Saharan Africa, we know that 70% of the HIV new cases, HIV infections, is in men and boys. That's quite a high percentage. And therefore, that is very, very, very important for men to be aware of that. Of course, prostate cancer, testicular cancer, and the next speaker will say more about the epi of this. Sexual dysfunction. We all assume that sexual function is just okay for everyone until they are 100 or above. But we do know that with age, we have high increasing prevalence of sexual dysfunction, with more than 50% of men 40 to 70 years describing some degree of sexual dysfunctions. Of course, we have the sexually transmitted infections that are quite prevalent in men and increasing as well. So do men have sexual and reproductive health conditions? Of course they do, and they are very, very prevalent, as you can see. So why should men seek sexual and reproductive health care? The first reason we want to give today is that men need to seek health services for themselves, for their own health and well-being. Remember that a lot of conditions don't show any symptoms until they are advanced, and hence the need for preventive and promotive services over and above the diagnostic, curative, and rehabilitative services. So do not wait until you have penile cancer to go for a checkup, or until you have prostatic cancer symptoms to go for a checkup. Make a habit to treat yourself better than you treat your car. Most of us who are here, we take our cars for service all the time, but ourselves, we don't even check anything. We just wait to see ourselves in the hospital. So we need to change that kind of attitude. The other reason that we need to seek health services, that men should do that, is for holistic management of their partners, in order to provide comprehensive and effective management. For instance, when you have a sexually transmitted infection, it will not affect you. It will affect your sexual partners as well. So it should not be left to the women alone to seek the treatment. We know in practice that a lot of men diagnose themselves by sending their partners to be diagnosed. We saw that a lot in the HIV system, and even in STI. So you have a urethral discharge and you tell your partner, go and be tested so that we can see if you have an infection. And sometimes it is even with violence and menaces. So we need to seek care for the purpose of our partners as well. And also for socioeconomic implications. Treatment of cancer is expensive. Treatment of STIs is expensive. We are having antimicrobial resistance now. You cannot afford to wait until you have advanced disease before you seek treatment. So we are only highlighting those 3 reasons now, but there are many, many more other reasons that men should seek care. Remember, prevention is better than cure, and early detection is key in prevention. Why prostate cancer? I will not belabor this point. I will only say one point here. Prostate cancer is curable if detected early. It is one of the, if God tells you, choose from all these cancers, the one which you would like me to give you, please choose prostate, okay? Please choose prostate, because for that one, you have a chance of cure. And with that, I would like to rest my case and go back to the coordinator. Thank you very much.
Thank you, Nancy, for this very clear call to action for all of us listening today to ensure we screen early and prevent sickness. Thank you. I'm never going to look at my car the same way again. On that very positive note, I want to introduce our colleague, Dr. Ilbawi, who is online. Andre is the WHO cancer team lead here at the Department of Non-Communicable Diseases in Geneva. Andre, are you with us? Can you hear us?
Good afternoon.
Brilliant. Welcome.
Thank you, Samira. I'm very sorry to not join in person, but I'm joining you from abroad on duty travel. Thanks to you, thank you to the ADGs, the chief scientist, and critically, thank you to all our participants for coming together to talk about men's health and to talk about one of the leading causes of cancer for men around the world. Prostate cancer. We've already heard the burden, 1.5 million cases per year around the world, but that number doesn't have context. What is easier to understand is that 1 in 8 men living in a high-income country like Switzerland or the United States will develop prostate cancer in their lifetime. 1 in 8. So in many regards, prostate cancer is a disease that will impact our families, our communities, for all of us. The challenge is the experience is very different. Nancy is right. If you live in a high-income country, you may be privileged to have survival approximating 95%, meaning 95 out of 100 men will live 5 years or more. But if you live in many countries that have weaker health systems, the chance of survival is much lower. People always start with a question of, is the cancer rate going up and why? Let's unpack that. So in the current setting, prostate cancer is more common in high-income countries, 50% of the burden or more. But it is rapidly increasing in many countries around the world. And one of the reasons that's the case is because of better surveillance and also because of life expectancy. So why does prostate cancer happen? The challenge is that there are many cancers that we know the root cause. Lung cancer, whether it be tobacco, air pollution, or other factors. But with prostate cancer, we do not have a very good sense of what causes it. The number one predictor of who is diagnosed with cancer is age. Of all modifiable risk factors, the primary modifiable risk factor is tobacco use, and that only contributes to about 6 or 8% of all cancers. So age. Age makes it very difficult because the presumption is, well, it's going to happen. Is there anything we can do about it? Yet, as Nancy rightly pointed out, there are still interventions we should consider today. In addition to avoiding tobacco, we also know that food intake, that is high fiber intake, low fat intake, can reduce the prostate cancer risk. And additionally, there is obesity, one of the biggest driving risk factors for cancer overall. Cancer is more common as men progress in their age. In fact, if you were to do a biopsy of men who are 75 years or older, more than half of them would have cancerous cells in their prostate. That is why, as you heard from Nancy, it is one of what we call the more indolent or less aggressive cancers. But it can still happen in young men, and it often does. In addition, it should just not be assumed that prostate cancer is a disease of age, because a lot of men younger than 60, particularly living in Africa, will be diagnosed with prostate cancer. And then what happens? What happens depends again on where you live. We know that the number one predictor of a man who develops prostate cancer to survive is whether or not he's living in a country that offers universal health coverage. A very simple analysis, but reinforces the message that prostate cancer is part of a broader health system response to cancer control and to NCDs or non-communicable diseases. So yes, better coverage means better care, better survival. But what about the other factors? Is prostate cancer survival being driven by factors like better treatment? What innovation is happening? Or early detection? As we've heard, early detection is key. So what does that really mean? Let's unpack that concept of early detection. We immediately pivot to screening, understandably so. And that is one of the primary discussion points we'll have today. Should a man be screened for prostate cancer? This is a point of discussion and intense debate for the past few decades. Historically, we have relied on prostate cancer screening because we know it can help us find more men and earlier disease. But that does not mean that at a population level, it is a public health intervention or priority. And the reason is this. Once you start looking for prostate cancer, you find that indolent disease. So you start treating men, and sometimes unnecessarily. In this sample population of 1,000 people, 160 men will be falsely alarmed and will have to undergo a biopsy. 20 men will be treated for a disease that wouldn't have caused them any difficulty in their lifetime. And as you can see, when screening programs are implemented, immediately we see a spike of cases without necessarily a decrease in deaths. So if not cancer screening for all, what do we do with prostate cancer early detection? There are two specific strategies. First, a targeted program, and second, early diagnosis. What does early diagnosis mean? Early diagnosis is having men be aware of symptoms, so if they develop any symptoms concerning for prostate cancer, they present in a timely way and, in fact, can be cured of their disease. This works. We know that most of the middle-income countries that are seeing reductions in prostate cancer mortality are seeing it because of early diagnosis programs. And when we even look at high-income countries, most men being diagnosed with prostate cancer are still being detected through symptoms and not through screening. So what are the symptoms? What is it that we as men should be aware of that would trigger a visit to a clinic and repair the car that we need? So if we look at the symptoms, the most important one to be aware of is urine hesitancy. Additional symptoms, urinating in the evening, increased frequency, blood in the urine. The challenge with this is we know these symptoms could also be because of an enlarged prostate, but that doesn't change what needs to happen. What needs to happen is present for a diagnosis, undergo a proper evaluation, and if there is a concern, a high PSA, a suspicious biopsy, seek care immediately. This saves lives. And indeed, we are also learning a lot more about prostate cancer. Not everyone needs aggressive treatment. A new policy of watchful waiting or active surveillance is working to avoid the harms that can come with prostate cancer treatment. So what are some of the key recommendations for the public, for those men around the world wanting to just know what can I do about prostate cancer? Of course, be aware of preventable risk factors as we presented earlier, and be aware of symptoms. Don't delay them. A workup can be simple, it can be fast, and it can save lives. Seek care and do so without delay. You'll have some lab tests done, you'll have a clinical evaluation, and ultimately you can detect a cancer early. If you're interested in screening, discuss it with a provider. And on the same point, providers need to be aware. If there is a concern, a family history, a high-risk characteristic, such as race or age, then screening can be appropriate. It's not to say a screening test is never right. It just needs to be done in the context of joint decision-making with men and according to the guidelines in a country. Many European guidelines are offering men optional prostate cancer screening. That is something that can be pursued in discussion with professionals and advocates to set the stage as to what are the benefits and harms of screening. And then for policymakers, there's a lot more that we can do. Prostate cancer has been neglected, and many men are feeling left behind. So what is it that WHO does? First, we're working to put prostate cancer in the agenda. This is just a concerning reference to show how far behind we are. When we looked at one of the essential medicines on WHO's model list of essential medicines and its availability in countries around the world, we found that less than 10% of surveyed countries have that essential medicine. We're actively working with countries so that they understand that these medicines for common treatment of prostate cancer are affordable, accessible, and can fit within the budget constraints of many countries around the world. The second, as we've heard, innovation. Prostate cancer is high on the innovation, with clinical trials for prostate cancer exceeding its disease burden. But that's not enough. We're working with the chief scientist, Dr. Farrar, and his team to start with a broader research agenda around prostate cancer and cancer more broadly, and also to initiate market-shaping strategies so essential technologies and medicines can be made available. Third, we have to deal with the recognition that prostate cancer doesn't have the same advocacy network. This is Google Analytics comparing breast and prostate cancer. prostate cancer receives about 1/10 the attention of breast cancer. And when we look at what happens, you can see these incredible spikes in the blue figure here. This is every October. Every October, there's huge interest in breast cancer, but there's very little interest for November. November is the month for prostate cancer or other opportunities to advocate for men and their health. And finally, as we've heard, we're leaving men behind. Many men are afraid of what happens after they're diagnosed, and that is causing delays in care and abandonment of treatment. Men are living with the potential fear of suffering the treatment complications from prostate cancer. And at WHO, we've launched a campaign to more meaningfully engage men that are affected by cancer. And it's a great privilege to share the discussion today with a man who has been affected. Prostate cancer will impact all communities. Prostate cancer can also have a lifelong harm on men. 30 to 80% of men with prostate cancer experience erectile dysfunction for the rest of their lives. It can be improved and it can be managed, but that number can be very intimidating to men. Men lose their jobs because of a cancer diagnosis, and we know that men, when they die, leave behind many children. Paternal orphans from prostate cancer is one of the leading causes of overall orphans from cancer in the African continent. And of course, it then has an effect on economies and communities more broadly. So it's a great opportunity. Thank you again for bringing us together. We can and should do more for prostate cancer health promotion, early detection, improving access to treatment. And we do this by focusing on how men want this agenda to be shaped. How do we organize, how do we present ourselves in a way that the agenda meets their needs as the highest priority? WHO is so pleased to see this elevated within our internal and external advocacy channels. Let's keep this going because there are many men around the world waiting to learn more about what they can do to improve their health, to repair the car, and to live a full and abundant life with themselves and their families together. Thank you again. Samir, back to you.
Thank you, Andre. This is definitely an insightful presentation for me personally, and I know what I'm talking to my husband about tonight. I want to make sure we move forward and now hand the floor to Dr. Massimo Velario, who is the chairman and head of the Department of Urology here at the Geneva University Hospital. Massimo, welcome. Could I ask you to tell us a little bit more about the services that are available in Geneva Canton to address prostate cancer and to support men in recovery and healing? Why is it important for men to seek timely help?
So first of all, let me say I'm very happy and I feel privileged to be here today. And would like to thank you, one of our patients who put this forward here and who is kind and brave enough to talk about his own experience for the good of everyone. So in Geneva, we are very lucky. In Switzerland, as an high-income country, we can really have a number of services to raise awareness and to provide an environment in which men, I think, can be felt heard and in which we can help in difficult decisions. And the decisions start very early on. So for the screening, as has been said before, screening prostate cancer is quite particular because obviously screening is to search for a disease which has no symptoms. In prostate cancer, there is no symptoms in most cases when it's an early stage. It's very prevalent, as has been said. And in addition, the factors are not really, you cannot really modify them. If you're a man, I mean, you can change that, but it's difficult. Aging, genetic factors, the tobacco use, the diet, obesity, these are more related to the progression, to the aggressiveness, but in terms of really incidence, it's little we can do. As opposite to female, males, they don't see their urologist. Females very early on in their life, they see the gynecologist, reproductive health, screening very early. For men, it's not the case. So there is a delay in seeking help. They don't usually go to see their GP, and the screening it's really start with the national programs. So colonoscopy, for example, for colon cancer, it starts from 50 years old. And for prostate cancer, yes, I mean, it's been said, the problem is it's tricky. If you do mass screening in terms of national policies, you will find a lot of cancers, but most of them will be indolent. It means they will not change the life expectancy. but it can have an impact on the quality of life because the treatment itself can lead to other kind of toxicities. So I think it starts with the GPs, and even there we have a lead time because most men, they don't go to the GPs when they are 50, they are 55. Current guidelines in men's in prostate cancer suggest to have early screening from 45 in case of genetic risk factors. So my friends, I'm around that age, do not go to see a neurologist or a GP. I didn't go to see a GP. So it's really not common. Once you have that, then you need really to balance the risks and benefits. I think any kind of intervention in medicine has its own benefit, but also the risks. Risk of being diagnosed with something indolent, risking of having toxicity, about invasive diagnostic interventions. I have to say, the new pathway with the adoption of MRI today has really mitigated a lot of the toxicity in the past, like having infection due to biopsy or finding a lot of indolent cancers. So really facing this. In Geneva, so I will say most cases it starts with the GP for the screening. So usually we say for men with long life expectancy and with no risk factors, so we start at 50 years old. Then we tend to personalize the frequency of screening according to the first PSA. And for men with with genetic risk, then we start early, 45, or Afro-Americans, we start early because they have more aggressive disease. Once there is a screening, which is done by a clinical examination and the PSA, in that case, in case there is one of both exams which are abnormal, then patients, men are sent to a neurologist. So in that case, it starts, to talk about what we should do. PSA is not a disease, so it's just a signal of abnormality, which can be related to many things. Anything to the prostate can prompt an elevated PSA. Doesn't mean there is a cancer. It's prostate specific, but it's not prostate cancer specific, which is old problem. So in case of a suspicion, then we will do a diagnostic test by means of MRI, and this is very good. This is one of the key messages. Today, MRI is very good for the disease because if you see a cancer on MRI, in most cases, it's an aggressive one. In other words, those which are indolent are not visible because there is not enough distortion of the anatomy of the normal prostate. So that's really a big advancement because before PSA was proportional to the aggressiveness, but not really correlated in a strong way. In case you have a positive MRI, then the suggestion is to go for a biopsy. And so in that case, you will have a diagnosis of cancer if that's the case. Having a cancer doesn't mean it's not a binary thing. You have a cancer which can be very low grade. In this case, it's something we'll monitor over time. It can be intermediate or very aggressive. And so it's really personalized about the personal risk and the expectation and the life expectancy of a patient. And so we go through counseling. Obviously, the word cancer is very difficult to accept. So it takes a while to just accept this word. And so there is a lot of support in this phase. And so the support is with our internal service. So we have a dedicated prostate nurse. She really takes care of the patients with the disease. And we have a network of support. So we have the Swiss League of Cancer. We have the English-speaking cancer support group. We have the PROSCA, which is another patient association of men who have been through prostate cancer. We raise an awareness campaign every November. I'm very sad it's not it doesn't give so much as compared to breast cancer, so we should learn from them. But we work a lot on this and really to raise awareness and to create support. Then we have all the support to patients with prostate cancer, which is not only what is the treatment option, but also how you will mitigate the effects of treatment on the person. Erectile dysfunction, for example, is not only the consequence of treatment, but it's also the mental health, the support you have, the counseling you have, the realistic expectations. And we really have an holistic approach, which I hope is good for the patient. And I think it's very good. I really ask for Sonia to be here today because she's very key to this and the support to patients. And I think it's, once you're diagnosed with this, it's a process which takes a while to accept and then to make a choice which is good for yourself. Different men with same disease can make different choices which are good for them. Maybe Sonia, you want to add something?
So thank you for giving me the opportunity to be here. And what I have to say, just every cancer, it's a person different, a situation different, and every man has their own way to deal with the cancer, because some of them already have someone on the family, they got a cancer. One of them is just the first time they heard this name. And I think my role and the role of the urology is to be there for the patients and the couple, because dysfunctional erection is not just for the men, it's for the couple where we have delayed with both of them. And again, every couple is different, every situation is different. And my chance is to have the confidence with the patients, and that it's really a chance. Thank you.
I think also when you contact a specialist, there are diseases that can be identified because they are correlated. For example, erectile dysfunction, there is a lead time between erectile dysfunction and cardiovascular disease, because the sites of the artery of the cavernous artery, which is for the erectile function, are the smallest ones with the heart. So they are very correlated. So seeking out for this may prevent you to have other diseases which can be very, very difficult to manage when you find them much further on. I think it's an habit. I think we should all, as men, to understand that to discuss about our personal risk, which is not only prostate cancer, but again, it's a number of things, cardiovascular events, mental health, and I think the movement of November really tries to raise awareness in this field.
Thank you, Massimo and Nancy, for your inputs. I think it resonates very much in my own personal experience. I think getting the men in our household to doctors, but also to speak to a counselor, is quite the struggle. So it's good to know this is a universal phenomenon. It's not just in India or in Europe, and that we are joined at the hip in making sure we can fix this going forward. Let me take some of what we've learned so far and now turn the page to hand the mic to Sanjay Acharya. Sanjay is a good friend and has been an inspiration in a different field, not health, for many. A lot of people will know him in the Geneva circuits as well. Sanjay, thank you for joining us. Thank you for bringing your experience to this discussion. And let me hand the floor to you. Would you be able to tell us a little bit more about your personal journey with facing prostate cancer? Why is it important for men to speak about the prostate cancer with professionals and other men as well as their partners? How did speaking up about it help you in your recovery?
Thank you very much, Samira. I was diagnosed with prostate cancer in June 2024, last year. I just turned 71, and I underwent robotic assisted prostatectomy under the able care of Professor Massimo Valerio at ASUG. That's the Canton Hospital in Geneva. So when I was leaving the hospital, after 5 days, I left a message on Facebook saying, I'm leaving the hospital, I'm going home after 5 days, leaving my prostate behind, in a lighthearted way. And I got a flurry of messages coming in from friends from everywhere around the world. A lot of men started contacting me separately saying, hey, I have the same problem. And can you tell me more about it? And there was really, I realized that, so I was at home the first few days, I started getting all this information, all this inquiries from friends who wanted to know more about what I'd been through and why I had been through it and what happened. And I'd gone home with a catheter, and I went back a week later to have it removed. Massimo was there and Sonia. And interestingly, Massimo said, oh, you worked at the UN. I worked at ITU. He said, you worked at the UN, and could you help us spread this message more globally? Because men don't talk about these issues. They really need to, but they don't. And I said, oh my gosh, I retired a few years ago. I don't know, I'm not in the system anymore, but I thought about it and I contacted Avni, who deals with gender issues, an old friend like Samira. And I said, could you help us with this? And she said, yes, we should talk about men's issues as well. Because gender, as you know, is normally about women. And she's sort of helped us to get here today. I think, thank you very much, Avni. And thank you very much, everybody at WHO, for hosting us here to talk about these issues. My own story started, let's say, about more than 10 years ago, while I was still at work, and I realized that something was not functioning quite well. I was having, my urinary stream wasn't strong enough, and sometimes I wouldn't reach the urinal, and that was a bit of an embarrassment at times. And also I found that my sexual functioning was not as good as it used to be. I didn't derive the same satisfaction. So I went and spoke to my GP at that time. And he didn't take it very seriously. He said, it happens, and so on. And then, but I kept persisting. I said, look, it's not right. There's something wrong. And I want to know more about it. But he said, why don't you have Viagra? And I said, well, my erections are fine, and I didn't want to get into this other aspect of having a Viagra. I didn't feel the need for it really. And I didn't know, I thought it might affect my health in other ways because I felt perfectly fine otherwise. Over time, my GP retired, I retired, and I went to another GP. And I told him about it. So why don't you have 2.5 milligrams of tadalafil, Cialis, as and when needed. So I said, it doesn't really help very much. And then he said, have 5 milligrams when needed. It was more of a placebo, actually. It didn't really do anything, And so this is how it just went on. And it wasn't, nobody was taking it seriously, but I kept persisting with my GP. I said, look, I'm not performing well enough. Something's wrong. But I didn't have all the other symptoms that people have had because I started reading about it. That going to the loo several times at night and things. I didn't have all of that. Anyway, then my GP started testing for the PSA, and it hovered around 2.5 for some time. And then in 2023, April or so, it went up to 4. And he said, I think you better go and see a urologist. So he referred to me to a urologist in Neo, and I went there. And he said 4, well, okay. And he checked me out. He did an internal checkup. He did the urine flow test and so forth. And he said, you seem to be all right. There's nothing really too bad, but we'll keep a lookout on it. And then in 2024, early 2024, I think it went up to 6. And by spring, it had gone to 12. I said, oh, this doesn't look good. You better get an MRI. It could be malignant. And I said, oh my God. This is getting into a bad space. And I said, oh gosh, this cancer. I thought I'd die of something else, but not cancer. Something, I don't know why, naively. I because of all my indulgences, I thought I might die of something else, but not cancer. But there it was, there was a whiff of cancer that was there now in the air. I had the MRI, and it revealed 2 lesions. And I said, this is getting serious. I spoke to a friend of mine who was also a very senior doctor at the Cantonal Hospital, and he introduced me to Massimo. And that's how I went to him. And he sort of laid it out very clearly, very, very clearly that, look, you have to have a biopsy. You have to get this done. And cancer means, I mean, there are different routes out of this. One is radiation and hormonal replacement therapy. But that also could amount to chemical castration in many ways. Or you do nothing about it. Nothing about it seemed quite good for me, actually, because who wanted to lose my sexual function? I mean, all of that, it was just too much to take. And anyway, I had the biopsy, and it revealed an aggressive cancer, a grade 4 cancer with a Gleason score of 8, which is borderline really bad. And my wife and I had a long chat with Massimo, and he explained very clearly what it was all about with the chart like that, which we just saw, the prostate and things, and and what happens and what needs to be done and so forth. And I went home and I said, gosh, Guy, you have cancer. You got to do something about it, because I mean, I enjoy being with friends like you and other people, and enjoy life. And I have a wonderful time with my wife and kids, and I didn't want to. I realized that cancer could really get bad if it spread. So I had a PET scan through Massimo, and fortunately, there was no metastasis. That was a safe thing, and I could go ahead with the surgery. And so I did. And I had a surgery at the end of August. But the thing was that, and also what happened was that Massimo introduced me to Sonia. And that was very reassuring for me, very reassuring. And also the fact that Massimo took me through all the steps that I needed to know. And Sonia, I was really, I have to say, incontinence. I thought I'd been a mess, pouring urine everywhere and wearing diapers. I didn't feel old, but I would feel old if I was wearing diapers, let me tell you that. And I was really worried that, I'll have erectile dysfunction, life would be nothing, it'd be zero. I mean, lots of things would go out. But Sonia was really reassuring. She sort of really said, no, you don't have to wear diapers. And, she showed me the pads. These are, very discreet things that be slipped into the underwear and things. And, so that's what I'm wearing right now. And also she said, I'll be there with you and I will see you right through before the surgery and after the surgery. I will teach you how to use the catheter and then after that, the pads and things. And also she would help me with the erectile dysfunction and all of those things. And I said, oh my gosh, this sounds reasonably good under the circumstances. And I think for me, really, it was a sense of understanding every step of the way, to learn the expectations and to know step by step before the surgery, during and after, what would happen to me. And a very dear friend of mine spoke to me from Delhi and he said, oh, you've got cancer and you're going to go through an operation. Just don't think about it. Let it all be in the hands of God. And I said, no, I have to think about it. I have to know every bit of it. And and it's really between me and my doctor. I mean, there's no God that's going to save me on this one, So, and I think that's really saw me through. But also, I kept on getting these messages from friends from all over the world, and I'm still doing it. It just continues. There's one friend who's also been diagnosed with cancer. He's a writer and so forth. And he just said he lost his mojo when he heard about it. He couldn't write anymore. He couldn't do anything. But he says when he saw my Facebook post, he thought I was very brave. I wasn't brave. It was just a lighthearted joke almost that I put out on Facebook, but he thought it was fantastic that, that he could actually talk to, and we talk a lot. He's all, even today, I was in touch with him. Another friend of mine from school, whom I hadn't met for more than 60 years almost, he's moved to Australia, and he said, look, I had the same thing. And why don't you get in touch with this woman who runs a website? It's called Victoria, a Touchy Subject. And so I got into that website, and there are lots of men who speak on those things, and she's very good. And I realized that there are lots of women, Sonia is one, and women who are really being very empathetic and help me go through this. My wife, in particular, has been very, very empathetic and supportive. And I think it's the women, as you were saying, Sonia, women are also very much a part of this. The thing is that men don't talk about it in front of women in particular. It's to do with their manhood, sense of virility and things, and they don't want to talk about it. But I think it's very important. And as Massimo's instance, I went to the cancer support group in Geneva. We're very, very good. They've really helped me. A counselor was helping me right through before the surgery and afterwards, and I'm meeting him again next week. I mean, they've been fantastic. And there's a prostate support group, men who've been through the experience, lived through the experience. And I said, why don't you involve women also in this group? Because, it's important. I mean, we men talk about women's issues, mastectomies and, cervical cancer. We know about it, and we talk to women about it. But women should be a part of this conversation as well, because I think is that empathy and understanding that we need from women, because to get over this, I mean, it's just not us. We work in society and people, and I think it's a conversation that we should have very openly. So I think I would really hope that, having come to this forum like this at WHO, which is a global organization, and that was our hope really, that at some point, this is the beginning, but at some point, if we could really make this a more global event, that we can have this conversation across the world really with people, in a more open forum, and bring both men and women into this conversation. Thank you.
Thank you, Sanjay. I think that's been a very inspiring account of your journey thus far, but I think in engaging all of us here today and in coming together, you are probably already kicking off the journey to changing this rhetoric and bringing change in the households, but also in the clinical settings where men are hopefully going to be seeking care. I just wanted to make sure we did hear from our last speaker today so we could complete the conversation that we have planned. We have Mr. Oswaldo Montoya, who's joining us from Washington, D.C. this afternoon. Oswaldo is a network associate with the NGO Men Engage Alliance. Oswaldo, just building on where we are at the moment in the discussion, could you give us a little bit more insight based on the work that you're doing on why masculinities and men's sense of manhood does affect their sexual reproductive health, as well as the choices they make around it, but also with the work that your NGO is doing with men globally, what have you learned about the barriers that men are facing in seeking help? Over to you, Oswaldo.
Thank you so much. Can you hear me well?
Yes, we can hear you. Please go ahead.
Well, thank you for organizing this important event. This topic is deeply personal for me as well. My father has prostate cancer. My father-in-law passed away from late detected prostate cancer. 3 of my close friends have undergone surgery treatment for prostate cancer. So, and I personally, I deal with an enlarged prostate or BPH, along with the symptoms that this brings. So this is very personal and also very collective, very social, very political as well. I see my urologist once a year, and I have this because of these symptoms, I have to go through this screening every year. I gone through digital rectal exam, and I have talked to this with my friends, in my work as well, with men. And it's so important to really talk about this, as the last speaker was mentioning. It's humbling. I think sharing about this is very humbling, and it challenges our cultural expectation about men, and that men should be always in control. Because for instance, in my case with an enlarged prostate, when I hit this, when I am, I'm hit with this overwhelming, urge to urinate, it's hard to wait, and it feels like you are not in control. And when you have to tell the people that you need to go to the bathroom as soon as possible, it can feel humiliating for men. So this is really an opportunity for men, even though it's a hard experience, to humbling, to become human, to really challenge the very the patriarchal script that we have been taught. And so, to respond to your question, I would say that sexual and reproductive health is not just physical function. We know it's about intimacy, it's about connection, and it's about connection with our own bodies, connection with also other bodies if we live our sexuality with others. And unfortunately, masculinity, patriarchal masculinity, teach us to, or train us to see our bodies more as objects, and to see other people's, others' bodies as objects as well, as objects to be controlled, instead of beings that we need to respect. We need to respect our bodies. We need to respect other bodies. We need to care for them. And that starts with listening, listening, being in touch with our bodies, and being in touch with the other people that we love, with whom we share intimacy. And this is the first problem, because if we are disconnected with our bodies, we disregard our symptoms, we disregard what our bodies are telling us. So patriarchal masculinity becomes a barrier, really. Patriarchal masculinity demands that we perform a script, be strong, be self-reliant, being potent, not being always in control. And this, in this patriarchal script, there is no room for vulnerability, for authenticity, for just being human. And so what's the result? Well, we start avoiding acknowledging that we are also humans, and we are aging, and that we need to be, that we are frail sometimes, and that we need help. And sometimes we are confused, we are afraid. So just being in touch with our own fears is so important, and acknowledging them. So I think in some way, this is the price that we men are paying for being put at this position of domination in the gender hierarchy. And so we develop a very precarious relationship with our own health, and that's very costly. And that's why these conversations are extremely important at all levels. And trying to normalize this, trying to really talk about this in a way that is normal, that is human, that it's okay to struggle with, controlled urination. It is okay, and it is a human experience to struggle with sexual dysfunction, with an ITS, with all these issues that we might be exposed. And talking about this in a way that is reassuring, that is supportive, that is not shameful, is extremely important. I think another barrier for men is acknowledging prostate issues is acknowledging our own aging process. And women as well has this similar situation, but I think for men, this idea of being youthful, or appear to be youthful and strong, is still there. And acknowledging that we are dealing with prostate symptoms, it requires authenticity, it requires strength. So so what I would encourage all of us, and this event is one way of doing this, is to promote new ways of being a man, to promote alternative narrative about masculinity is to tell men that our health, taking care of our health, is also a way to be responsible with all. It's also a way to show strength. Asking for help is not weakness. It's a sign of courage. You know, I really admire the friends that I mentioned, and one of them is right now in the hospital in my country, in Nicaragua. They have been talking to me and they have been sharing with others. One of them actually also posted in his Facebook page about his experience. And one of the things that I admire of them is that in some way they have taken this, they have gone through different processes, but one is talking about this, including humor. I think we need to normalize this and recognize that there are some situations that we can, it's not about making fun of others, but it's about finding humor in these situations. One of my friends was telling me that he had to go through a second surgery because the prostate enlarged again after going through a first surgery. And he was telling me, I think my prostate thinks that it's a banana tree because now it's growing back again. So in a way that is joking, that is making he himself trying to find humor in these situations. So I think it's very important that we also promote ways, what we are doing here, storytelling, sharing about our personal experiences. That is very important. That, as the previous presenter mentioned, that really invites other men to also break the silence and start talking about this and start making clear that many of us are struggling with this, and we can talk about this and we can support each other. And there are health institutions that are also learning how to be sensitive to men and support men. And this is a communal thing. When we men disregard about our own health, women pay a price as well, because then they have to pick up, our pieces. And so it's also a collective responsibility for men to take care of our own health in order to support our families, in order to support our communities, in order not to become a burden. And if we get sick, ask for help and have the humility to be supported. So thank you really for this event, and this is just for me a reminder that the experiences of men are complex. We are the subject of so many privilege, but at the same time, we are paying a high price for this privilege. And of course, men are different. We have to have an intersectional lens. Men are in different positions in society, and men are different. I mean, every individual is different. So we have to consider also those factors in the work that we are doing. Thank you.
Thank you, Osvaldo. Extremely important words, especially when you mentioned that asking for help is not a sign of weakness, but a sign of strength. I think the conversation has to start from the very beginnings of how we're socializing ourselves in this society, but also how we as women are encouraging this vulnerability in our interactions, besides the conversations that need to happen between men as well. Very, very important insights here. Thank you very much. And also for the work that you're doing with your organization. I want to now bring us to the question and answers. We have had a couple of interactions posed by the audience that's listening in. And let me introduce our colleague, Dr. Avni Amin, who's with us here today. Avni is the unit head from the WHO Department of Sexual and Reproductive Health. Avni, do you have a couple of questions that we could pose? Over to you, please.
Thanks, Samira. We've tried to address some of the WHO ones online. So for those of you who pose questions in the Q&A, I think our WHO colleagues have answered them online with specific questions. I just wanted to flag a message that we had from Andre Ilbawi, who's the team lead from Cancer, who unfortunately couldn't stay because he's on duty travel. And he said, he just said, it's a pleasure to be here. Thank you for organizing. It will be really appreciated by staff, and it is long overdue to raise their attention to this important issue. One of the questions that we got and we have answered in the chat function is for Massimo, which is, what are the resources for WHO staff, particularly the ones who are based in Geneva, when they get a diagnosis? And we have actually responded to this in the chat with a list of web links that you can see for resources for WHO staff, for any other UN staff that are based in Geneva, to reach out to those resources if they get a cancer diagnosis. A specific question to Sanjay is, what is your advice to those tuning in, either for themselves or for their loved ones that are newly diagnosed with prostate cancer? So what would you, as somebody who's gone through this process, give advice to the ones who might be struggling with a diagnosis?
Well, I would imagine that they've already gone and got a diagnosis from a specialist. So they should really follow through. I had these options that Massimo put out very clearly to me. And I think the most precise way of getting rid of that cancer is surgery. Because the others, as he explained to me, radiation therapy is imprecise. It could, and once you have it, you cannot take surgery after that. It doesn't work. So surgery, I think, is the best option. I had the surgery to this Da Vinci robotic assisted procedure, which Massimo is an expert in, and I really came out feeling, quite well after the surgery. I was not feeling unwell. It was just that I had issues to deal with, incontinence and other things. But I mean, I was driving the second day, and Sonia just said, "Of course you can drive." This kind of reassurance, this kind of support is very useful. So I would say that if you've got a diagnosis, get it treated.
Can I say something?
Yes.
So I think obviously Mr. Acharya talks for his case, and his case, it means we always say there is the disease and the person, and the two things are equally important. You can have the same disease, being a different person and choosing different things, so being the same person and different expectation, priorities. So I don't think I ever said radiotherapy was not precise. I think both modalities and even active surveillance have different things. And so it's a question of priority, it's a question of life expectancy, it's a question of bowel, urinary, erectile function, and different treatments will have different outcomes. And we can't say here, robotic surgeries for everyone is the best choice, otherwise it will be much easier. And, all the counseling is about really choosing the best for yourself. And that's why it's difficult, because we have a multiple choices, and each one is good for one person with one disease. It takes time just to choose. I think it's not something which is urgent. My advice to people is to take their time. I think some patients, it's very different. Some patients say, well, you decide. And we always say, we will not decide for you. So you need to take your time. You need to you need to be an expert in a way. You need to make your choice. You can only do a good choice if you know what you're choosing. So I think the advice is don't panic. In most cases, it's found by screening, by early detection. So we don't know how long it takes. Doing this in an hurry is never a good option. So take your time, seek help, talk to people who had surgery or radiation or active surveillance, survivors, patient organization. Sonia is the deputy president of a patient organization on prostate cancer in Geneva. These are really good things. And what you said about, it's mostly about to manage the unknowns. When you manage what the unknowns become knowns, it's much easier.
We have one quick follow-up question for you, Massimo. Can you tell us what might be some of the delays with respect to screening in Geneva? Or either Sonia or you, if you want to speak to any delays that might occur for men receiving screening and diagnosis in Geneva. And then I have one question on to Osvaldo, but I will pose that afterwards.
So we'll talk rather about early detection, but we'll say, yeah. So the early detection or informal screening is done with GPs. So it's really about seeking out with your GPs and talking with him or her about the benefits and the potential toxicity of having a screening test. And that's really dependent by the GP. I would say is very, very quick. Then the delay, we have a certified prostate cancer center. And so we have a 2 weeks delay, which we need to respect for every patient. It means that if we have a referral, we need to see the patient the 2 weeks following the referral. In other centers might be a bit more.
Thank you. Sonia, one question to you is, what is your advice to the patients you see around conversations, including to women, around how they can best support men who with a prostate diagnosis and treatment, and also to both you and Massimo around, and even Sanjay, what would your advice be to women and men in terms of how to start a conversation with their GPs? How should men especially approach this conversation with their GPs about prostate cancer? So maybe Sonia, if you want to answer the question about women partners and the importance, and what should they do?
Thank you for the question. I think the first way it's to communicate it. I think men need to learn to talk. Because I think sometimes they just are afraid to know what are going to happen to them. So it's difficult to talk about that to your wife or to your partner because you are afraid. And the cancer, the word cancer is difficult. The erectile dysfunction is difficult. Incontinence, it's horrible socially to feel if I work, because some of them still work. So I think they just need to learn to talk, and when they talk and they communicate it with the wife, it's easier with the partners. And about the GP, to talk about prostate cancer, I think after 50 years old, you can ask just to have a check of your PSA, just to know how it is around and to know how but be careful, because the PSA that we said before is just a number. It's just an indicator. It doesn't mean, just one, it's not enough.
So first of all, I will say the personal story of Mr. Ashaya is very important, because you really seeked for that help. You were really asking for this, and you really spotted your disease when it was rising. The good time. I think if a man shows up to his GP, well, the GP will talk about this, about colonoscopy. These are standard things. Now, the problem at the global level is that 10 years ago, we said, well, we should not do screening because we will find a lot of indolent disease. And then we said, don't do screening unless you're very, very well informed. And then the consequences of this today are that the informal screening doesn't work at all. For instance, in the UK today, there is a trial which is called Transform, because in the UK, decades of age in which you get your PSA is between 70 and 80. That's the first decade. The second one is 80, 90, which doesn't mean anything, because the screening should be much, much earlier. So that's the reason why we are rethinking how to implement early diagnosis in the real world. But I think it's very easy. If a man around 45, 50 will show up to a GP, he or she will talk about this.
Question to Osvaldo. Osvaldo, thank you for your plain speaking and letting us know about your experience coming through the understanding of masculinities. Can you talk a little bit about going beyond the biomedical model and speak about why aging and masculinities is an important frame or lens to address this, as the person saying this is an everyday issue for them, confronting the age and the masculinities intersection when discussing this?
Yes. Well, it is important, I think, because it's about identity. Our gender is one of our core social identities that many of us have. I mean, in the case of male identity people, men, those of us who feel ourselves as men, it's an identity that we carry. We are socialized into that very early on in life, and we will die with that male identity. Of course, we are trying in the work that we do. We are trying to soften that identity, that male identity, to expand it, to make it more inclusive, and not to worry too much about this male identity and embrace a wider sense of identity as humans. And yet it's still important. I still feel that I am a man, and that's an identity that influenced my life. So it's about changing the meaning of that identity. And so talking about prostate issues and sexual and reproductive health matters. It's an area of our identity that is very has a lot of emotion. And so it's about how we see ourselves, how we think others perceive us. And I think it's an opportunity when we go through health crisis, it's an opportunity for change, really. I want to invite men and those of us who work with men for transformation, for creating a fair society, a just society, for creating equality. It's an opportunity for transformation, for recognizing that we need each other, we need our communities, we need our families, that we need to be more attentive to our own issues, and that we are just other humans that go through issues that some of them are preventable, of course. I mean, and we can do our best to reduce the likelihood of bad health outcomes, but we are never in control. We are never in full control. We can, contribute to our health, do self-care and inform ourselves and all of that, and still recognize that we are fragile as humans. And so it's about that opportunity, that humbling opportunity that creates these issues, and we're gonna face it one way or another. Some men with more risk than others, but we are gonna face one or another way of decaying, and we can face that with grace and with an opportunity to continue our human growth, our personal and even spiritual growth. So yes, let's take this beyond the biomedical. I agree with that, and still include information about our bodies and what experts in the medical field tell us we need to engage with them. Nowadays, there are more opportunities to educate ourselves, to access to better information. Of course, education might be a barrier, but for many men who have had the opportunity to go through school, and now we can inform better and ask better questions to our doctors, and have this conversation in our families and with our peers in a more inspiring and supportive way.
Question for Nancy. I think you heard from several of our panelists about the importance of men interacting with their GPs for early detection. And yet, if we know in Switzerland, as Massimo has pointed out, as Sanjay and Sonia have pointed out, these services are available. What is the global situation with respect to services available for men to discuss sexual and reproductive health issues? And what can we as WHO do about it to highlight the evidence and policy gaps with respect to service availability?
Thank you for that question. I will start a bit and then I will request my unit head to comment about the work that we are starting in this area. As we have all said, services for men generally are limited in most places. For those of you who live in Geneva, please take advantage of the availability of services and seek care. But for most places, either we do not have health workforce that have the competencies to even examine the male reproductive system, or safe spaces where the men can go to where they feel comfortable enough to discuss their issues, or health workers like Sonia here, who are responsive and who know what to say and how to say it. Those are completely rare things. And we do recognize that, and we realize that there's a lot of work going on in terms of trying to ensure that men at least can be able to access these services. We are currently undertaking a review to map out the organizations at global level that are supporting men's reproductive health services, but we have other streams of work that I will request James to speak to.
Thank you, Nancy. So I think definitely for men, they are like Swaldo outlined, patriarchal masculinities that make it hard for them to access services. But those are issues, as I think ADG pointed out, that are cultural and they are very complex and that will take us a lot of years to address. There are also service barriers on the side of service provision that make it difficult for men to access and use services. So I think a low-lying fruit, and this is what we are trying to initially address, is how can we set up our health systems so that they are more responsive to men as the men are currently? How can we make them be able to access these services? As we are planning to have a task team to first, of course, identify those areas and what actions we can take. In the area of contraception, we know already men actually contribute 27%. Male methods are men, so they are already in the system. But how can we expand this? So we are doing some research to look at ways in which we can expand male methods, looking at ways in which we can reach men with infertility services and also with STI services. So I think it's very important that we address both sides of this coin, both the issues that make men not to access services, but also look at the health system and address the factors that are actually a barrier to men accessing the services. Thank you.
Thank you. That's it from the Q&A. Over to you, Samira, for the final.
Thank you, Avni. Thanks to all our colleagues online and those that have joined for all of your questions, but also making this a very informative, very memorable session. I want to thank all of our panelists who are here today. But before we come to the end of this webinar, I wanted to make sure I invited Dr. Pascal Alote, Director of the WHO Department for Sexual and Reproductive Health, to give us a few closing remarks.
I have to admit, I'm sitting here with mixed emotions on a day when it appears that patriarchal male masculinity is winning the whole geopolitical discussion, and listening with a lot of heart to the discussions and the contributions that we've had from the panelists. So Thank you very much. And I have to say, it's a real indication of the importance of this topic to have our ADG sit here for 90 minutes with us, because at this time in particular, and on this day in particular, to have someone like this sit through and really listen and engage in this discussion is really important, and it says a lot about WHO's commitment to this topic. So as we draw this important discussion to a close, I'd really like to reflect and get us all to reflect on the urgency of the issues that we've discussed, the challenges that remain, and the path forward. The reality is men's sexual and reproductive health has been neglected in global health discourse. I wouldn't necessarily pitch this as a competitive vulnerability between men and women, but it clearly does require attention. The neglect is not benign. It has profound consequences for the well-being of men, their partners, their families, and their communities. Masculinity often acts as a barrier, silencing men from speaking up about their health concerns, seeking care, or accessing the services, and we've heard about this. Breaking the silence is not just necessary, it is urgent. Prostate cancer, as the leading reproductive tract cancer in men, exemplifies this urgency again, as we've heard. Between 2016 and 2023, WHO and partners like UNFPA spearheaded groundbreaking work to prioritize research on engaging men in sexual and reproductive health and rights. Among the key questions emerging from this work was, what are effective ways of addressing men's own sexual and reproductive health in, dare I say, gender transformative ways? This question is not just academic, it is profoundly practical. It is about creating a world where men feel empowered to seek care, to speak openly about their health, and to access services without stigma or shame. It's very clear that this issue is not just, we haven't just addressed the clinical issues, but there clearly is something more that we need to be doing to address this. And we know that addressing men's sexual health isn't just about the men. It's about building healthier relationships, stronger families, and more resilient communities. A man who receives timely treatment for prostate cancer not only prolongs his life, he's also preserving the emotional stability of his home and contributing to the well-being of his partner. So where to from here? First, we must challenge and dismantle the norms of toxic masculinity that keep men from seeking help. And as you've heard, we have a research agenda and including a very strong gender and rights advisory panel. Oswaldo used to be on that. Second, we need to strengthen health systems, and therefore having Bruce here is critical to ensure that services are accessible, inclusive, and designed to meet men's unique needs in ways that are gender transformative. To ensure that we have up-to-date global guidelines that enables context, values, and preferences to be appropriately applied, particularly in resource-constrained settings. And finally, we need to prioritize research to understand the barriers that men face and identify effective interventions that can be scaled globally across a range of sexual and reproductive health conditions. So to every man listening today, and to the professionals who support them, I want to say this. Speaking up about your concerns is not a sign of weakness, but of strength. And seeking help is not only a gift to yourself, but to the people who love and depend on you. I leave the discussion, therefore, with a renewed commitment to breaking the silence about sexual health and a future where seeking care is not just an option, but an expectation, one that reflects the value of every individual's health and well-being. And to everybody who has contributed today, thank you for your dedication, your insights, your passion, and Nancy, always entertaining to listen to you for addressing these issues. And we look forward to working with you all and to build the evidence base that strengthens sexual and reproductive health and well-being for all. Thank you.
Thank you, Pascal. And with that, we will now close this webinar. We want to wish you all a brilliant journey ahead, starting conversations and supporting the cause. Thanks, everybody.